Afternoon, everyone. Thank you so much for being here. My name is Erica Solway, and I'm the Manager of Signature Initiatives and Partnerships at the University of Michigan Institute for Healthcare Policy and Innovation, and Deputy Director of the University of Michigan National Poll on Healthy Aging. We're delighted to welcome you to the fourth and final session of the 2023 University of Michigan Healthy Aging Series. The Healthy Aging Series is a collaboration between the 4 community programs at Michigan Medicine's Turner Geriatrics Clinic, which include the Silver Club Memory Programs, Osher Lifelong Learning Institute, Turner African American Services Council, and Turner Senior Wellness Program, and the Turner Geriatrics Clinic, as well as the National Poll on Healthy Aging and the Institute for Healthcare Policy and Innovation at the University of Michigan, and new this year, AARP. The title of today's session is Navigating Your Medicare Choices and Benefits. With open enrollment underway and options abounding, today you will get the latest on what to consider, how to choose wisely, and how to get the most out of the plan you select. You will also get to learn about Medicare tools, updates, and benefits, and hear suggestions on how you can talk to your doctor about your options. We will have about an hour for today's presentation, followed by approximately 30 minutes for questions. And before we get started, I want to say a few words about Zoom, our presentation software platform. When using the Zoom webinar platform, the main thing that you should know is that you should be using the Q&A icon to submit questions. So to submit a question, simply click the Q&A icon at the bottom center of your viewing window and type and submit your question, which will go to me as the moderator. While there also is a chat icon, please don't use that for questions about the lecture. Please use the Q&A instead. And please note that we now have a closed caption option for you if you wish. On your Zoom computer screen, you will see an icon labeled CC in the meeting controls. Click on it for either closed caption or a live transcript of the presentation today. Finally, if you encounter any technical issues, such as your screen freezing up, the best way to alleviate these issues is to exit out of the webinar and then join us again. But if technical difficulties persist, feel free to call the Turner office at 734-998-9353. This session will be recorded, and once it's edited, will be uploaded online to the website at mishmed.org/healthyaging. We will email registrants with the link when it's available, and we encourage you to view the recording and share it with others. And now I'm delighted to introduce today's speakers. First, we will have Shari Smith. Shari is the Manager and Regional Coordinator of the Medicare Medicaid Assistance Program for the Area Agency on Aging 1B, a nonprofit focused on helping older adults and family caregivers. Prior to working at the Area Agency on Aging 1B, Shari was the Village Director at Jewish Senior Life of Metropolitan Detroit, where she worked with community residents to create an age-in-place network. Before switching to geriatrics, Shari was the manager of the WIC program for the city of Detroit, the director of family services at Sinai Community Institute in Chicago, and the administrator of Chicago maternal and child health programs for the state of Illinois. Shari also spent a year in rural Kenya, East Africa, running a hospital and teaching administrative skills. Shari holds a master's degree in international development and a master's degree in public health. And next, I'd like to introduce our second speaker, Dr. Renu Tipirneni. Dr. Tipirneni is an associate professor of internal medicine at the University of Michigan Medical School and a member of the Institute for Healthcare Policy and Innovation. Renu's research focuses on investigating the impact of health reform policies and programs on low socioeconomic status, aging, and other populations, and on the delivery of care in the healthcare safety net. Her current work includes examinations of access to care under health reform, Medicare decision-making and experiences for diverse populations, Medicaid policy, integration of behavioral and physical health care, and assessments of social determinants of health in clinical practice. Dr. Tipirneni's clinical practice includes primary care hospital medicine for adult patients at Michigan Medicine and at the VA Ann Arbor Health System. She completed her medical school training at the University of California, San Francisco, and her health services research training at the University of Michigan. As a reminder, please put any questions that come up for you during the presentation in the Q&A box, and we'll do our best to get through as many questions as we can. Thank you to Shari for kicking off today's conversation.
Thank you, Erica. And good afternoon, everybody. Pull up my screen. Can people see my screen? Or does it look wonky?
It's
Can
good.
everybody can
It's
everybody see my screen?
Yes, thank you.
Okay.
Looks good.
Okay, good. Thank you. So what we're going to cover today are sorry, it moved on me. What we're going to cover is a brief overview of what Medicare is, what's new to Medicare for 2024, why you should review your health plan every year, what to look for when reviewing your plan, and I'll talk a little bit about the MAP program and how we can help you save money. So briefly, Medicare is divided into 4 parts. It's insurance for 3 people, those 65 and older, people 65 and under with certain disabilities, and those of any age with end-stage renal disease. It has 4 parts to it. Part A is hospital coverage, which covers your inpatient care, your skilled nursing facility care, hospice care, and home health care. And home health care is almost always skilled care. It's nurses. People often think that Medicare covers aides who can help bathe you or get you dressed, and Medicare almost never covers that. Part B is your medical insurance, and that's your service from your doctors, your outpatient care, your home health care. Again, same thing, it's skilled, durable medical equipment, and preventive services. And that's what we call original Medicare. It does not cover drug coverage, so people need to add a Part D prescription coverage, which covers your prescription medications and some vaccines. Medicare calls that optional, but if you don't enroll timely, you'll be stuck with penalties that will follow you for the remainder of your life. So it's optional in that you have the choice whether or not to enroll in it, but if you don't enroll, there are penalties. And then the other way to go is to get a Part C plan, which is Medicare Advantage. And those bundle your Part A, B, and D into one plan. They're HMOs and PPOs, and these plans may offer extra benefits. So this slide shows the different paths. So the first part is your Part A, hospital insurance with your medical insurance, adding your Part D, and then you can also add a Medigap plan. Medigap plans are plans that are sold by private insurance companies, and they can help you with your out-of-pocket costs for original Medicare, because original Medicare doesn't cover everything. It's an 80-20 plan. So Medicare pays for 80% of the cost of care, and you pay for 20%. Medigap fills in those blanks for you. Medigap are also labeled with letters. So there are plans. So there's Plan A, there's Plan D, and original Medicare is Part A with Part D, just to make it confusing for people. Then there is the Medicare Advantage plan, which bundles your Part A and your Part D, B, and your Part D. Part D is covered in most Medicare Advantage plans. There are some Medicare Advantage plans that don't include drug coverage. Usually those are for people who perhaps are veterans who get their medications at the VA. So original Medicare updates. The 2024 Part B deductible went from $164.90. It's going to $174.70, which is a $9.80 a month increase. Most people don't even realize they're paying their Part B because it comes out of their Social Security, but please note that you will see a $9.80 decrease in your Social Security checks. And the Part B premium went up from $240 to $226. And that's a 14% or $14 increase. The premium is what needs to get paid one time a year when you're using your Part B services. The Medicare Part A deductible for people who are admitted to the hospital without a Medigap plan went from $1,600 to $1,632. The deductible covers the beneficiary share of costs for the first 60 days of Medicare-covered inpatient hospital care in a benefits period. Beneficiaries have to pay an additional $408 for days 61 through 90 and $816 per day for hospital stays beyond the 90th day. If you have a Medigap policy and you're going with original Part A, you probably won't see these costs, or you'll only see a few of them. Beneficiaries in skilled nursing facilities will find that days 21 through 100 in the benefits period has gone up. I believe it's $6 to $200 a day. There's a small number of people who actually pay for their Part A monthly premiums. In general, if you've worked 10 years or 40 quarters, you don't pay your Part A premium. It's free. That's what the money coming out of your paycheck for Medicare is covering. If you haven't paid into the system enough, there are costs, and those have gone up. The maximum is $506 a month for 2024. So that would be only if you haven't worked or your spouse hasn't worked the proper number of quarters. We don't know what the cost of living increase is going to be yet. So hopefully it's going to go up higher than your Part B monthly premiums. Last year, the Part B premium decreased and Social Security went up, but we don't know what's going to happen yet for this year. We should find out in early 2024, if not sooner. So what are the things that you need to consider when you're joining a plan or when you're looking to switch a plan? You want to look at your premiums, which are the amount of money that you pay generally every month. You want to look at your deductibles, which is the amount of money you have to pay before your plan kicks in to pay. And then there's your copays, which is how much you have to pay every time you use the service. The senior savings model is the Insulin Reduction Act, which now shows that insulin is $35 a month for all insulin products. But those are the true insulin products, not things like Ozempic that help with diabetes, but aren't considered insulin. So you always want to look if your drugs are covered, what tier your drugs are in. Do you need prior authorization in order to get a medication? Are there quantity limits? If your doctor prescribes you 45 pills a month, but your plan only lets you get 30, that's something you need to consider. Is there step therapy, which means that you have to try drug A before you can try drug B, which your doctor may have recommended. You also want to look at if there's nationwide coverage if you're traveling. And then you want to look at your pharmacies, which are the networks that are contracted with the insurance companies. So are they in network? Are they preferred? Do you like mail order? Is mail order less expensive? These are all things that you can find in the Medicare.gov plan finder, but there's so many different things to look at that we always recommend that you talk with a counselor, because we'll ask these questions to you and we'll be able to filter properly. There can be hundreds of dollars of difference between one pharmacy and another. And if you don't know that, you may feel that that's the price that you have to pay, when in fact, if you go a couple miles down the road, you may be saving $100. Additionally, your formularies can change, your doctors can change, your medications can change. So we recommend everybody get what we call a benefits checkup every year and talk with a MAP counselor, because we can help you look at these things. If everything's good, it's a 15-minute visit. If you need to make a change, we'll look at alternatives for you. You can take them home. Maybe you'll call us back, or you can make a decision right there. But we're here for you. We are funded through Older American Act dollars. And so we are really your taxpayer dollars at work. And we'll provide 100% unbiased information for you. So when you're looking at a Medicare Advantage plan, you also want to consider the same things. You want to look at your premiums, deductibles, and copays, and all the coverage issues. But then there's another step that you need to take because you're in a network that you have to go see the doctor in. So are your physicians and specialists, are they in network or out of network? PPOs tend to have an out-of-network benefit. If you go to a doctor that's out of network, you may end up paying more, but you can usually get that paid. HMOs tend to keep you in network. And if you go out of network, you're responsible for 100% of the cost. Do you like your doctor? Do you want to, if they're out of network, are you comfortable switching to a new doctor? Or do you want to find a new plan where your doctor is in network? Additionally, Medicare Advantage plans offer other benefits. They all offer some dental, vision, and hearing benefits. A lot of times they're comprehensive, sometimes they're just basic. Most plans also offer a separate rider that you can purchase that will get you an enhanced level of benefits. A lot of plans offer fitness benefits. They also offer medically necessary transportation. Some will offer meal service if you need it for short periods of time. Some will offer home modifications for safety, such as grab bars, and telehealth and more benefits. So when you're choosing a plan or when you're looking to switch, these are the things that you need to consider. What's important to you? Do you want to be able to go wherever you want to go, whenever you want to go without a referral? Then that would take you most likely to original Medicare with a Part D and a Medigap. If you're comfortable staying in network with your doctors or with the charges that go out of network, or maybe you want the dental and hearing because that's important to you, then you might want to choose a Medicare Advantage plan. This slide's out of order. So Medigap plans are, as I mentioned, they are lettered as well. They go from Plan A to Plan N. If you were on Medicare prior to December 2020, you may have chosen a C or an F plan. Those plans are no longer available. The new plan is the new Rolls Royce of plans would be a G plan or an N plan. And if you have a G plan, you will basically pay your premiums. And when you go to the doctor or if you get admitted to the hospital, you'll walk out paying nothing. The other plans offer more limited benefits, but still cover a good deal of what's important. And they're now starting to offer dental, vision, and hearing benefits and some gym memberships at an additional cost. But what's important about that is you have to find a provider who's actually going to take those benefits. And I anecdotally have heard that people have a lot of difficulty finding a doctor who is willing to take some of these plans. So these are things that you'd want to look for and contact your doctor or dentist ahead of time to make sure that they'll take these plans before you sign up for them. And then on the right side of the screen are some of the companies that are offering additional Medigap plans. And the other thing I want to mention about Medigap is that you have a 7-month enrollment period when you're first signing up for Medicare. So you have the month that you enroll and you have 6 months following that to enroll in a Medigap plan without the possibility of being underwritten. You have a guaranteed right of issue, which means that they must issue you the plan at the prevailing rate. And it doesn't matter what illnesses or disabilities you're coming into that plan with. However, after that 7-month period, you lose your guaranteed right of issue and they can underwrite you and the prices go up. So what I always advise people is when they're looking, if they're starting on Medicare, to think carefully about what path they want to go on. And if they think that they want to go on the original Medicare path, to know that they've got a certain period of time that they will sign up for the plan to save money. Otherwise, the price could go up. So there's a lot of new things in the Medicare and New 2024 book, and I would offer to send them out to people, but we didn't get ours this year. We usually order 400 of them and we didn't get any. So we're stealing from our parents. But things that are new in the books are that starting in January of 2024, if you have prescription drug coverage and your coverage is high, your drug costs are high enough to reach the catastrophic phase, you don't have a co-payment or co-insurance. You used to have to pay 5%. Now you don't have to pay anything. And extra help will expand. So if you have trouble paying your prescriptions and you are at a certain income level, they used to give you what was called a partial subsidy or a full subsidy to help pay for your prescriptions. They're eliminating the partial subsidy, and anybody on a partial subsidy will now be eligible for the full subsidy. And if anybody who's listening is getting a partial subsidy, please know that Social Security will be taking care of those transfers. You don't have to do anything. Social Security will make the switch for you, and you will get a full subsidy. There are now lower costs for insulin and vaccines. Vaccines are free. If it's a Medicare recommended vaccine, it is free. It will either be charged under your Part B or your Part D, but you should not have to pay for your vaccines. You may have to pay a copay if you go to your doctor's office for the office visit, but you will not have to pay for the vaccine. And as I mentioned a little bit earlier, if you take insulin, it will be $35 for each insulin. If you take 2 insulins in a month, it will be $70. There are some changes to telehealth through the end of 2024. After 2024, what we understand is that you must be in an office or medical facility located in a rural area to get most telehealth services. And there's going to be exceptions that we understand for mental health services that you'll still be able to get telehealth. And Medicare is now offering, or will be in 2024, services to treat chronic pain if you've been living with it for more than 3 months. Whoops. It looks like my slides are moving on their own. I apologize. I'm talking and it's just moving. I apologize. Oh, it's going the wrong way. Now I feel really embarrassed. I'm really sorry. I apologize. I have to get back to where I was. And there we go. I wasn't touching anything. Okay, here we are back at that. My apologies. So Medicare will now be covering services for chronic pain if you've been living with it for more than 3 months, including some acupuncture benefits. There will be better coverage for mental health care. Medicare will now be covering intensive outpatient services provided by hospitals and community health centers if you need it. And COVID-19 vaccines, tests, and some treatments will be still free of charge. So there's different enrollment periods for Medicare. And right now, for people who are new to Medicare, there's the initial enrollment period. And that is generally 3 months before you turn 65, the month you turn 65, and 3 months after. And when your benefits start depend on when you enroll. Right now, we're in the annual or open enrollment period for Part D. And this is the one time during the year that you can change your Part D plan if you're not happy with it. And this is where we recommend everybody look at their drug plan and look at all the things that were mentioned a few slides earlier. You can also change your Medicare Advantage plan during this time period, but Medicare Advantage also has a special enrollment period during January 1 through March 31st. However, you must have a Medicare Advantage plan on January 1 in order to take advantage of it. And then there are also what we call special enrollment periods. And there's a number of reasons why somebody would get a special enrollment period. These are periods that will enable people to make changes in their plans for certain situations. One is if you have, for example, an involuntary loss of credible coverage. So if you've lost your job for any reason, if you're moving, there may be other exceptional circumstances. If you are on Medicaid or get a low-income subsidy, you have a special enrollment period in which you can change your plan once a quarter. However, during the annual open enrollment period, October through December, the plan that you select will take effect in January, not the following month. And another thing that's really important to note is COBRA. And please note that COBRA is not considered credible coverage for Medicare Part B by Medicare. If you are on COBRA and you want to sign up for Part B several months down the road, you may find that you have a penalty that will follow you for the rest of your life, because even if it's the same plan that you were getting through your work, Medicare doesn't consider it credible coverage. Some Part D plans do count as credible coverage. This is something that you would want to talk to your human resources rep or to call us if you were concerned about it. So there's a lot of things with employee coverage that you need to know. And the biggest source of information for you is going to be your human resources person. It's important to know these answers if you're going to delay your enrollment into Part B. So if you're still going to work and you get your Part A, for example, because it's free, but you want to delay Part B, you're going to want to make sure that your insurance coverage is credible. When you are ready to sign up for Part B, there's some paperwork that needs to be filled out by Human Resources and by you to submit to Social Security so that they know that your plan coverage is credible. You also need to know if your plan is primary or secondary to Medicare, because if it's primary to Medicare, you may have to have a Part B plan, because otherwise Medicare may say you don't have a plan, and you will have a penalty. So these are things to consider when you're 65, if you're going to continue to work when you sign up for Medicare, and we can also help you with those answers. The thing we don't want to have happen is to have you end up with a late enrollment penalty. The three main takeaways that come with this is that you should delay Social Security and decline. I'm sorry, I didn't talk about health savings accounts. If you have a health savings account, there are time periods from which you have to start or stop submitting to your health savings account, depending on when you're working. So if you're going to decline Part A, you can continue to contribute to your health savings account. If you decide to delay enrolling in Medicare, make sure you stop contributing to your HSA at least 6 months before you plan on enrolling in Medicare. This is because when you enroll in Part A, you receive up to 6 months of retroactive coverage, but not going back to your initial coverage date. If you don't stop submitting to your contributions at least 6 months before, you may incur a higher tax penalty. Again, this is something that we recommend speaking with your human resources representative or a tax professional on how your HSA will work with Medicare. We just bring it up because it's something that's important for you to know as you're considering your choices. And this slide actually shows the path that you can take if you're going to enroll in Part A and or B, or if you're going to delay enrollment. And we can make these slides available, I believe, to everybody if you're interested in seeing them. I mentioned before that there's premiums and deductibles for your Part A and Part B, and your Part D, and your Part D premiums are also subject to income adjustments. They're based on a sliding scale depending on your IRS tax returns from 2 years prior. This is called your IRMA. It's the income related Medicare adjustment amount, and every category has a set amount associated with it. if you might qualify for an IRMA, then you can call us and we can help you with that. So this is the 2024 Part D IRMA. So if your income is below $103,000 a year for an individual, or $206,000 for an individual, looking back 2 years prior, you don't pay an IRMA on your Part D. You'll just pay the $174.70. As your income goes up, there's a dollar amount that will be attached to your Part D premium that you'll pay. And if it's the same income categories, but if you're in a Part B, then there's a different amount that you'll pay. This $244.60 is not in addition to the $174.70. That's just what you would pay for your Part B IRMA. Whereas in the Part D, it's an additional amount that's added to your premium. If you think you're going to be subject to an IRMA and you've had a change of income since 2 years prior, for example, let's say you inherited money 2 years ago, so your income was higher and now it's lower, you can contact us. We can help you with an appeal for your IRMA. There is a process to go through, and we can help you with that, so you're not paying on money that you don't have for the year. So we've all heard about the donut hole, I think, which is really what we call the coverage gap. In past years, when you hit that amount for Medicare, you would end up paying 35% of the cost of the drugs, and the insurance company would pay the remainder. For 2024, the donut hole has, we call it, disappeared. What that means is that you're going to pay 25% for your generic medications, 25% for your brand name medications. However, you could end up paying more in the donut hole phase, because if you have a drug that's $100 and you pay $20 a month copay for your drugs, when you hit the coverage gap, you'll be paying 25%, not 20%. So you may end up paying $25 a month for your medications. And I have a chart that illustrates this a little bit better. So this chart shows you the different coverage periods and what the dollar amounts are. So the red section is your initial part of your plan where you're paying for your drugs. The green part is when you hit your deductible and your plan starts to kick in to pay for some of your medications as well. When you reach $5,030, and I know that this is a lot of money of out of pocket, and that includes what you've paid and what the plan has paid, you hit the donut hole, and that's where you'll pay 25% for your medications and generic or brand name. The troop is your true out-of-pocket costs. So when you hit your troop, which is $8,000, which includes what you've paid, what the plan's paid, if you're getting any prescription drug assistance programs or manufacturer's discounts, or if for the insurance company, the actual retail cost hits $12,447, you hit the catastrophic phase, and that's the blue section. And in that section, you won't pay anything for your medications when you hit that amount. Why is it moving? I don't mean to take that lightly. It's a lot of money, but Medicare has made a reduction, and you're not going to pay 5% anymore in the catastrophic phase. If you need help paying for your prescriptions, the Social Security Administration has a subsidy called Extra Help or Low Income Subsidy, and it helps with the cost of your Part D drug coverage. It helps pay premiums, deductibles, and copays. I apologize, the screen should have changed to 2024, but the income and asset guidelines are going to change. However, if you think that you might qualify, or you just think you need help, please call us, because we'll help you out. There's lots of other programs out there that can help people pay for their drugs. We've heard those commercials on TV that say, if you can't afford your medications, AstraZeneca can help. Well, we have all the information on the different insurance programs that help out people, the pharmaceutical programs and other programs that can help people lower their drug costs. Additionally, things that you'll find at the pharmacies like Good RX cards, for example, or any other prescription cards that you see, those are all legitimate and you can use them and those will help lower your drug costs as well. So how do we do all this to find out what's going on? We use the Medicare Plan Finder, which is at medicare.gov. This is something that you can use, and it's something that our teams are highly trained to use. So again, we recommend caution if you're going to use it yourself. But what you do is you create a login. This is if you're already on Medicare. If you're not on Medicare or you're new to Medicare, it's a little bit different. You create a login and that will provide a personalized search. If you're already on Medicare, it's going to pull up a list of your medications that have been billed to Medicare in the past year. It allows you to be able to compare the cost of your medication, the deductible pricing, the monthly premium pricings, and it also will let you select pharmacies so you can see the differences in costs between different pharmacies. You can also do an anonymous search, but it won't save your medication list. If you do this on your own and you pull up your medication list, be sure that you edit out any drugs that you're not getting anymore or add in anything that's new if you want to get accurate costs. The Plan Finder also has a star rating system to measure how well Medicare Advantage and Part D plans perform. Medicare scores how well plans perform in several categories, including quality of care and customer service. Ratings range from 1 to 5 stars, with 5 being the highest and 1 being the lowest, and plans are rated in each individual category. Medicare also assigns plans 1 overall star rating that summarizes the plan's performance as a whole, and beneficiaries can use the star rating to compare performance among several plans. Medicare does review the plans yearly and releases new star ratings each fall, which means plan ratings can change from year to year. When you're considering a star rating, be sure to consider all the other factors as well, because if a plan's 5-star, but your drugs aren't covered in it, then it's not a good plan for you. Additionally, in an effort to promote better plan quality and better choices, Medicare will be sending notices out to people who are in Part D drug plans or Medicare Advantage plans that fail to get at least 3 stars for 3 straight years. We'll let them know that they're eligible for a special enrollment period to enroll in a 4 or 5-star plan. Medicare has also put warnings on the Medicare.gov screens for the lower performing plans. And if you want to go in a low performing plan, and they're usually the least expensive plans, there's a warning and you actually have to call Medicare in order to enroll in the plan. You can't do it online. They make sure that you talk to somebody so you understand that it's a low performing plan. And every year you should get an annual notice of change in the mail, and you should look at it because it's going to tell you if your premiums, deductibles, and co-payments have changed. If your drugs are still covered, are they still on the same tiers? Are there restrictions? It won't show you if there's another plan that offers better coverage, but when you look at the things above, you might decide that you want to find a plan that will provide you better coverage. And here, this is telling you again about the low performing plans. So the Inflation Reduction Act has had some impacts on Medicare and drug prices, and I want to briefly go through those. In 2023, they put a cap on the insulin, and they put a vaccine copayment reduction. We're in 2024 now, where they have eliminated the 5% coinsurance for a catastrophic level, and they've expanded the low-income subsidy eligibility. Something that's very exciting for 2025 is that there's going to be a $2,000 out-of-pocket cap on Part D drugs. Right now, the sky's the limit on what you can pay for your drugs in Part D. And that is something that's been pushing more people towards Medicare Advantage plans because they have an out-of-pocket limit, at least on healthcare, not on drugs. But there will be this $2,000 cap, and it's something to consider should you be thinking about a Medigap plan, because you may say it's very expensive this year, but you can manage it next year, and you don't want to miss your guaranteed right of issue if you don't enroll in a Medigap plan timely. And for the next few years, there are going to be negotiations on drugs. And by 2029, 60 popular high-cost medications will have had the drug prices negotiated, and we should see lower prices. So I want to also take a minute to talk to you about fraud, abuse, and scams. We are what's called the Senior Medicare Patrol for Medicare. It's a nationwide program that helps people to be educated on how to detect, keep safe, and report scams. It's funded through federal dollars, and during open enrollment, scammers are out in force, and you really need to be careful, especially with artificial intelligence. You can really be fooled, and things to know, first of all, is don't be embarrassed if you got scammed. It happens to people. Please call us. We can help you. You don't want to pay that extra money if it can be avoided. You want it reported. You don't want it to happen to somebody else. So please don't be embarrassed if you fell for a scam. Things to know about marketing, which will help keep you safe, is that marketers can't endorse themselves as market themselves as Medicare endorsed. So if you see someone marketing themselves as Medicare endorsed, or even having an image of a Medicare card on their information, please don't use somebody like that as an agent. They're violating the law. They can't solicit you from door to door. They can't leave materials on your doorstep or in your mailbox. They can mail you, but it has to go through regular mail. They can email you, but the email has to have an opt-out on it. If it doesn't have an opt-out, they're violating the law. They can't call you if you're on the do not call list. I know people get those calls anyway. You should check the do not call list periodically to make sure you're still on it. They can't enroll you during a solicitation call. They can't leave you a message on your phone if it's unsolicited, and they can't approach you in a public place to talk to you. Don't trust mailers that come out that look like they're official government communications. Make sure that they are. Please read the fine print. If you're not sure, please contact us. Never feel pressured to enroll in a plan. We won't pressure you. We don't sell you anything. We're not licensed to sell you anything. We're not affiliated with any insurance companies, but you should never feel pressured. You should always say no if you're feeling that, and go home, give us a call somebody else, and keep yourself safe. We advise people not to answer the phone if they don't know who's calling. And if people want to talk to you, they'll leave you a message. Please know Medicare will never call you. The IRS will never call you. We won't call you unless we're returning a phone call to you. And again, be careful with artificial intelligence, because they can make the voice sound like somebody that you know who is in need of money somewhere. And the best thing to do with that is, let's say you get a call that your granddaughter is in need of money, and it sounds just like her. Tell her you'll call her right back. Hang up, call her mother, or call the number that you know is her, because people are getting scammed out of thousands of dollars, and Medicare fraud, abuse, and scams is a billion-dollar industry that's costing all of us money, because when Medicare pays for services that aren't delivered, we all pay. Check your explanation of benefits and Medicare summary notices every month to make sure anything that you're billed for, or that Medicare is billed for, even if you're not, is a service that you've received. If it's not, the first thing to do is to call your provider and say, you billed me for this and I got that. A lot of times it's just a billing error and they'll correct it. If it's persistent, it could be a scam, and you can call us, because a lot of a lot of times, or maybe not a lot, but there are some physicians out there who will bill Medicare, and people who will bill Medicare, they get your Medicare number and are able to bill, and Medicare ends up paying for things that you didn't get. And you need to be safe on the with the radio, phone, and internet. The TV and radio ads make it sound like these are the best plans in the world. You're going to get a card to go to the market, and you're going to get transportation, and you're going to get food, and you're going to get all these things. And you might, if you qualify. And if you read the fine print or you listen very, very closely, you may find that there's a lot of costs involved in these plans. And by calling the number on the plan, you may actually find yourself enrolled in the plan. And then you have to call us to disenroll you. It's much better to not call those people in the first place. If you're looking for a plan that's going to provide you with a lot of different services, we can help you find that. And we can do it legitimately. So please, understand that a MAP counselor can help you understand your plans. We can help you compare and enroll in your plans. We can help you identify and report fraud, abuse, and scams. We can assist you with enrolling in low-income programs. We can also help you with appeals and a number of other services if it's something that you need. And if it's something that we don't do, we will find the people who do it for you. If you want a personalized MAP appointment, please call us at 1-800-803-7174. We do counsel year-round, but this is our busy season now with open enrollment. This number is a geo-directed number, so it doesn't matter where in the state you are. It's the same phone number. The first thing that's going to happen is it's going to ask you to put in your zip code. And that's going to direct you to the proper area agency on aging into their MAP program so that they can help you. I can tell you at our office, which does serve Southeast Michigan, you will probably get voicemail after that. Please, please, please leave a message. We receive more phone calls than we have people to answer the phone, but we do call you back. We call every single person back. I've been here for 6 years. And nobody has been left in our callback system at the end of open enrollment who needed an appointment. So please be patient, but please give us a call because we're here to help you. And know that the Area Agency on Aging also has many other programs that can help you out. And again, this is our phone number at the bottom, 800-803-7174. And if you flip your Medicare and You 2024 book over, at the very back, it's going to say for personalized information, or if you need help with your Medicare, call your local SHIP, which is a state health insurance number. And that's our program, and that is us. And you're going to see that same number, 800-803-7174 on the back of your Medicare and You. So please give us a call. It's open enrollment. We don't want you to miss the boat. And if you have a Medicare Advantage plan, know that you can enroll also or switch your plan from January 1st to March 31st. And with that, I want to thank you all for your attention, and I'm going to turn it over to Renu Tipirneni for the remainder of this program.
Thank you so much, Shari. I know you have presented such a tremendous amount of valuable information, and I hope to talk a little bit about piggybacking on that. And I wonder if you can take your slides down. I'll put mine up. Thank you. Looks like I need to be enabled for screen share. Great. I just want to see, can everyone see my slides okay?
We can, they look good.
Thank you very much. So I wanted to reintroduce myself. I'm Renu Tipirneni. I'm an internal medicine doctor and health policy researcher focused on Medicare and other insurance policy and decision making. And I wanted to tell you a little bit about how to talk to your doctor about insurance, like all the different plans that Shari just mentioned, how to talk to them about care related to that insurance, and medications, including navigating medication costs today. So starting with talking about insurance plan options, I think you can talk to your doctor to see if they recommend, you know, one versus the other. One example is many people, as they're enrolling, will decide between traditional or original Medicare with the additional plans like Part D, or Medicare Advantage, which rolls them in together. I just want to mention some things you can consider. One is, since Medicare Advantage has a more limited set of providers in the network compared to traditional Medicare, you can consider which networks your current healthcare providers are in. So, you know, whether that's looking at the provider directory on Medicare Advantage plans, if that's something you're considering, or honestly asking that doctor or their office directly, which is usually the most reliable way, you can start to get a sense of whether the doctors you currently are seeing and want to continue seeing are going to be a part of that plan's directory. Thinking about medication costs, you know, a lot of that hopefully will get better in the coming years, as Shari said, under the Inflation Reduction Act's changes. But right now, if you start to notice your medication costs are rising, consider whether it makes sense to switch your Part D drug plan, or consider whether it makes sense to switch between traditional Medicare and Medicare Advantage. There isn't really a one-size-fits-all recommendation here, but it is all to say, you know, it really makes sense to check every open enrollment what plan would be best for you. I will say it's really easy just to stick with the plan you've got. And if nothing's changed, feel like, okay, it's still going to cover my costs. But sometimes the plan itself may change what amount they charge for out-of-pocket costs for different medications. So it's just something important to keep an eye on. The other thing to consider is whether you need any additional insurance benefits. So if you think about Medigap plans covering dental or vision care, or if you're thinking between traditional Medicare and Medicare Advantage, you can think about which Medicare Advantage plans cover those. As Shari pointed out, a lot of Medicare Advantage plans do cover those dental and vision care benefits. I also wanted to talk a little bit about getting preventive care under Medicare, since that's a lot of my focus in primary care. One thing to know is that preventive care is generally covered without co-pays or additional costs to you by both traditional Medicare and Medicare Advantage, so no matter which pathway you choose. And it's really important to help find those health problems to be able to start any needed treatments early. And I see this all the time where when we are able to prevent those issues, we can prevent health complications and keep people healthy and living the lives they want to live. What are some of the specific types of care people get under Medicare? There are a couple of different types of wellness visits I wanted to draw your attention to. One is the Welcome to Medicare visit, which you're eligible for within the first 12 months that you enroll for Medicare. And that includes a careful review of your medical and social history by your doctor, a height and weight check to calculate your body mass index, make sure that's healthy, a vision screening test that's very simple but helps get a sense of whether you need some more vision care, overall health counseling, and depending on your specific circumstances, other screenings or shots to prevent illness in the future. Not only when you first enroll in Medicare are you eligible for that wellness visit, but you can actually get an annual wellness visit every year after that. And in addition to that review of your medical history, again, it includes a blood pressure and weight check like before, and health advice in the form of a personalized prevention plan. So your doctor should be doing general screenings that include hearing, you know, fall or other kind of functional abilities, you know, to do your activities of daily living. But they should also personalize the advice to you. You know, what specific screening tests should you get? When are you due for different tests? What specific shots should you get? And you should be getting that in some kind of summary at the end of that visit. What kinds of preventive screenings or services does this potentially include? You know, for most people who are eligible for Medicare, they should be eligible for cardiovascular disease screenings, which most often is in a cholesterol blood test up to every 5 years. And that shouldn't be, like you'll see for many of these costs, it shouldn't be any cost to you. But if it's associated with a regular doctor's visit, you may have, depending on your plan, a 20% copay or coinsurance for that doctor's visit. Mammograms, you know, up to every year for women 40 and older should be available at no cost. Sometimes we say do those screenings every 2 years, depending on your risk level. Colon cancer screening, there are various options for that, including colonoscopy, which you can get every 3, 5, or 10 years, depending on your risk level, or even stool tests to screen for colon cancer. And in general, those shouldn't be any cost to you unless it's part of a doctor's visit that you have other eligible co-pays or co-insurance for. Prostate cancer screening for men over the age of 50 who want the test. This is one of those tests that they recommend shared decision-making for, depending on your specific risk level and preferences. Flu shots, which are eligible one per season or one per year, and other types of shots like pneumonia or pneumococcal shots. Now with the newer pneumonia shots, most people should only need one in the lifetime and then are good for the rest of their lifetime. Bone density or bone mass screening. Usually we start this at age 65 for women and consider repeating it depending on the results if they're deemed higher risk. So that's why we listed up to every 2 years as needed here. What are some other screenings? If you're high risk for glaucoma, you're eligible for that screening every year. Or if you're higher risk for diabetes, you can get 1 or 2 blood tests per year. For pap smears or cervical cancer screening, while most people complete the screening by age 65, some people have follow-ups from prior abnormals or other have higher risk for other reasons. And so they can still get those tests up to every 1, 3, or 5 years, depending on their risk level. HIV screening through a blood test is recommended at least once in a lifetime for everybody, but you can get this test every year as needed, depending on your risk level. And COVID vaccines for those interested, that still is kind of depending on the CDC guidelines, but right now we're seeing it once a year. It has been available at no cost, but it's kind of in a changing landscape right now after the public health emergency. I also wanted to mention a couple of specific services that are only specific people are applicable to need, but if you're smoking and interested in quitting smoking, wanted to mention that Medicare does cover up to 2 counseling sessions per year and also covers prescription medications. So since nicotine patches are available over the counter, they're not typically covered, but other types of nicotine replacement like inhalers or sprays are covered, as are other prescription medications. There are a couple of different pill medications available to help quit smoking. And then the diabetes prevention program is a really great program for people who don't currently have diabetes, but are at risk for diabetes based on potentially having a borderline blood sugar test, higher body mass index, or other risk factors. And it's a 6-month intensive program available with a health coach with the goal of reducing blood sugar and preventing diabetes. And researchers found it very effective, and Medicare was actually the first plan to cover this program at no cost, and before other health insurance plans picked it up. One thing I did want to mention that most people don't think about when they're going in for these wellness visits is that sometimes you're doing a lot of things with your doctor in those visits. And so these wellness visits are supposed to be available to you with no additional cost. And sometimes if you're discussing other visits, that may be considered another office visit for other problems. So I recommend that you make sure to tell your doctor that the focus for you of that day or that visit is wellness or prevention, so that they make sure to really only bill you for that wellness and prevention visit, which shouldn't be extra cost to you. Sometimes, and this is actually kind of nationwide, we see this, clinics will bill both for preventive visit and for a regular office visit, and then you'll get that, bill for like a copay or co-insurance for the regular office visit. So just reminding them, actually, patients remind me and my staff all the time, and it's helpful because you can still address it after the fact, but dealing with the billing office is always harder than dealing with the doctor's office first thing. I also want to mention how to talk to your doctor about medication costs. I think a lot of people think there's only one medication that's possible if that's the one my doctor is prescribing to me. So I first want to say there's often a lot of different medications available in that same class of medicines that are equally effective. And sometimes doctors are just picking the first one on the list. But for that reason, I recommend asking your doctor to check the level of coverage that you have for that medication based on your insurance and how much that copay would be. Many offices, for example, my office has someone in our office who specifically helps check these issues. What kind of copay would the patient have? And so it's helpful to inform that process. Or if it would be a high copay and you find that out, you can actually ask your doctor if there's another similar medication that works just as well that they would recommend. So for example, say it's for blood pressure. There's so many highly effective medications for blood pressure. They may have just started with one recommendation, but there's actually another one that's equally effective that costs less. Or it may be something in the same class of medicines. There are often several medications that work very similarly, but that there's just 1 or 2 covered by a specific insurance formulary. So I just wanted to mention that because sometimes people don't feel like they can be activated to ask those questions, but actually most doctors' offices have people in the office dedicated to helping work through these issues and lower your overall out-of-pocket costs. The other thing I want to mention is maybe you've been on a medication for a while, but you suddenly notice a change in the cost of that medication. And, you know, it makes sense to do a couple of things in that case. First, ask your doctor to recheck your level of coverage, because sometimes the same plan may change how they cover different medications, even though you've been with that same health, you know, say Part D plan and on that same medication for a while. And then see, is there actually another medication that's very similar that's, you know, considered the preferred medication now by your Part D or other prescription drug plan, and they can actually make that switch there. The other thing to consider is if you have rising copays for several medication, you do want to talk to your doctor about what are the most important medications for your health. Obviously, as a doctor, I recommend you take all the medications that are prescribed, and I still think that you should. But knowing how to use that information to prioritize which plans you select during open enrollment, for example, for Part D, is really valuable. And even thinking about what other plans you may be interested in to support that. I know Shari mentioned that overall, we're looking forward to 2025 when out-of-pocket costs for medications will be capped at $2,000, and hopefully that's still a lot of money, but you know, potentially a lot less than the current maximum. So hopefully, you know, affordability of medications will be getting better and better. And I want to stop there because we want to leave plenty of time for questions. But Shari and I are both very happy to take questions. I know I'll give it back to Erica because I know there's some questions that were submitted even in advance of the webinar.
That's correct. Thank you, Renu. Yes, I'm thinking we've gotten so many terrific questions already, and maybe we'll go through a couple that relate to the remarks you just gave, Renu, just to cover those quickly, and we'll try and go through as many questions as we can. So the first one here, just relating to your recent remarks, is the updated COVID vaccine covered under Medicare?
It should still be covered, and really, I know we're worried about necessarily the future, but it should still be covered for you at no cost. And sometimes it hits different parts of the plan, but it should still be covered at no cost.
Thank you. And how about nutritional counseling covered for prediabetes?
That should be covered. And actually, there's different pathways for prediabetes. One is that structured program I mentioned, that diabetes prevention program, but actually general nutrition counseling is also covered, and it's really a great approach as well.
Terrific. And then we got a question submitted in advance, which relates to one of your last comments. The person said, I'm totally baffled by the prescription coverage for Medicare. This is Medicare plus Blue Cross, but this is about a specific drug, Eliquis, where the price jumps all over the place. So a 3-month supply went from $345 to $400, 1 month supply $45 to $81. And just you mentioned that drugs within the same plan can change, the price can change. Anything more to say about that?
Yeah, this is probably a class of medications that many people on this webinar are on, which are blood thinners or anticoagulant medications. Eliquis is an example of one of the kind of newer, but I mean, as of several years, like really effective medications in this landscape. And what's happened is that it seems like they change their preferred medication within this class frequently, not just specific to Medicare, but drug plans in general. I don't know why, but for these anticoagulant medications and also for inhalers, just over the last few years, I've seen those formularies changing constantly. And so it may be that your plan is suddenly jumping between preferring Eliquis or similar medications in that class, like Xarelto, for example, is another one. There are several others in that class of direct anticoagulant medicine. So I guess I would say I wish it weren't the case that every few months this is changing, because it should be more like on a every year basis, is what we normally see with insurance formularies. The other thing I'll say is it's kind of interesting. Not only did Shari mention that out-of-pocket costs will be capped at $2,000 in 2025 under the Inflation Reduction Act, but Eliquis is in one of those first 10 set of drugs for which Medicare is negotiating drug prices. Xarelto is actually another one. And so I'm really curious to see if that'll moderate the overall cost of these important medications.
Thank you. That's very helpful. And it sounds like it might be a perfect case where maybe talking to your doctor could be helpful if it is bouncing. Great, thanks. And I'm going to go to some broader questions now too. Someone asked, how do I find the drug formulary?
The drug formulary should be listed in your annual notice of change that you get every year. But if you happen to throw that out, which a lot of people do, if you go to the plan's website, you should be able to find the formulary. It may take a lot of digging, but it should be there. But you don't always need to look at the plan's formulary. What you want to find out is to find a plan where the drugs that you're looking for are covered. And that's something that the plan finder does really well for you.
And I'll just add, if you're ever not sure and can't find that information, reach out to your doctor's office, because they usually have someone in most practices that are familiar with pulling up those drug formularies, so they may be able to help you too.
Yeah, we can do that as well, but your doctor's office can probably do it faster.
And Shari, another question about kind of where to get additional information. This question's about getting premium costs for Medigap plans. The person says they aren't listed on the 2024 guide, only Medicare Advantage plan premiums.
There's about 200 companies that offer Medigap plans, and so they can't list all the costs, and the plans are, the costs are different depending on where you live. So for example, I was working with my cousins in Florida, and they were moving from the Fort Lauderdale area up to the Palm Beach area. And their Medigap price was different depending on the same plan, but depending on where they were living. So we can give you really good estimates if you're looking for plans. We have a proprietary plan finder that can give you a really, really good estimate of what the different plans are going to cost you and the proper phone numbers to call. So for example, if there's a Blue Cross plan that you like, you don't have to go through the phone book, or there's no phone book anymore, but the internet, and decide which is going to be the right number. We can give you the right number to call for that. So if you're looking for Medigap information, please feel free to call us and we'll do a search for you.
Great, thank you. And another Medigap question. This person asks, if they entered Medicare at 65 and are now in their mid-80s, is it possible to change to a Medigap policy with better pricing?
It's really difficult to do that because you've lost your guaranteed right of issue. And what Medicare's, or what the plans are going to do is say, well, you're 80 years old, so therefore you're probably at a higher risk for higher medical costs. So they will up the price of the plan, or they could even decide not to insure you. That said, we can give you the information and you can call the plans and find out. We do caution people too, if they've got a plan and are looking to switch to another Medigap plan, which is very difficult, do not cancel the current plan that you have until you get proof that you are actually enrolled in the new plan, because you may find that something went wrong and you're out of your plan and you can't get it back.
There was another question, Shari, about when someone has a Medigap plan and then is diagnosed with a condition like dementia. They ask, is it true that no other insurance company will cover them?
If they have a Medigap plan?
This is a Medigap plan and the person is diagnosed with dementia is the question.
So if you have if you have A and B and a good Medigap plan, all of your healthcare services should be covered. And it doesn't matter what you're diagnosed with, it should be covered.
And you can't be dropped, is that correct?
You can't, they can't drop you from the Medigap plan unless you stop paying.
Okay. Thank you. That's helpful. And then someone asks, I like what I set up 10 plus years ago, assuming when they first enrolled in Medicare. Is it really worth trying to figure out other options?
Absolutely. You may not need another option. You may still be on the best plan for you. But if the issue is simply who's going to pay for your medications, if you find a plan that has a lower deductible, a lower premium, and lower drug prices, why should you pay more for that? So it makes sense to look. People have saved hundreds of dollars by changing their plans, especially if you've been on a plan for a long time. There are plans right now that are for next year are going to be $5.20 a month. And all plans have to cover a wide range of medications. So it's not that the cheapest plan isn't going to cover medications. They'll still be having to cover a wide variety of medications in every class.
Thank you. And then a question was, how do I know if I can stay in my current provider network or if I should switch to a Medicare Advantage plan? So that I'm assuming this is someone who's got traditional Medicare and is wondering whether Medicare Advantage would be better.
There's no network for traditional Medicare. You can go to any doctor anywhere in the country that takes Medicare assignment. So there's no network. And so you're all set. If you want to switch to a Medicare Advantage plan, then we would want to check and make sure that the doctors that you want to see are in network.
And I'll just make a follow-up there. I already mentioned this earlier, but just make sure to call your current doctors because some of those provider network directories are out of date and they should be kept current, but it's better if you make sure with the doctor's office that they're all still enrolled.
Absolutely.
Thank you. Excellent point. Thank you for that. And someone asked, is it true that if you enroll in a Medicare Advantage plan and then later develop some health issues and with that additional costs, that Medicare Advantage plans can deny payments for some of those conditions or costs?
They can't really deny payment, but they can initially say that you're not eligible for some treatment. They can, but then you can appeal it, and we can help you work with your doctor's office to appeal a denial. If it's a Medicare covered service, they have to cover it. If it's a service that Medicare doesn't cover, they don't have to pay for it. But with a Medicare Advantage plan, everything that traditional Medicare covers with the A and B, Medicare Advantage plans have to cover as well.
I just want to say, I agree with Shari. Definitely don't hesitate to talk to your doctor's office. We file appeals not just for Medicare, but all the time for other denials that obviously sometimes don't make any sense, and we just have to submit some extra documentation.
And there are stages to denials or to appeals. So you might appeal one time and get denied again, and you can keep appealing up to, I think, an administrative law judge, I believe, is the highest level that you can go to. So if it's something that you and your doctor really think you should get, then know that you may have to go through some steps, but there are people who can help you with that.
Oh, great. So good to know that there are options for people. We had a question about someone who has a Medicare Advantage plan and was recently diagnosed with a serious complex condition. And they were wondering about their ability to access expertise through places like the Mayo Clinic or MD Anderson. Obviously it might be specific to the plan here, but a question about a new diagnosis maybe requiring or that leads someone to want to go elsewhere to seek consultation or referral for their care.
It's not impossible to do that, especially if your plan has if it's a PPO and it has an out-of-network option, then you can do it. You may need prior authorization, so don't just show up there. But it's not unheard of that you can do that. And with traditional Medicare, of course, you can go anywhere. And depending on the network, and I'm not sure how Mayo works, but for example, if you've got a Blue Cross Medicare Advantage plan and there are Blue Cross network doctors working at the Mayo Clinic, then they could very well be in network for your plan. I don't know if Renu, you have.
Yeah, I guess I totally agree. The only thing I'll add is it's sometimes we actually place referrals as a second opinion. So that's what, like when you may have gotten your regular care somewhere and then people want to go to the Mayo Clinic or some specialized center for a second opinion. And so it ends up looking slightly different in that regard. But yeah, I think the network out of network, if they're out of network, they're probably going to cost a little bit, or not a little bit, substantially more than they would in network, but it's still possible if you're in either traditional Medicare or then if you're Medicare Advantage and you have, a broader network, like Shari said, that includes some of these specialized centers.
Great, thank you. And Someone asked about that they travel abroad and we're told that they need a Medigap policy that will cover that. And we're wondering if that's true. And I guess maybe also to broaden that question for people who do a lot of travel, whether it's domestically or internationally, what are some considerations as it relates to making decisions around Medicare?
Well, traditional Medicare will cover you anywhere in the country with any physician or medical care facility if they take Medicare assignment. If you have a Medicare Advantage plan, again, it's the in-network, out-of-network issue. HMOs tend to have very limited networks, and often they can be just very regional, that even if you go up north from Ann Arbor, they may not cover you except in an emergency. Medicare doesn't cover you out of the country unless it's sometimes very near the US border. There are a couple Medicare Medigap plans that will cover you for 80% of international travel. Again, you have to make sure that you're eligible during the time period to sign up for that Medigap plan, but they do cover you. But another option, because I do a fair amount of international travel, is you can always get private insurance to cover you. Some kind of traveler's insurance that will cover you for your travel while you're traveling. It's not always cheap, but it may be an option for you if you decide that Medigap isn't the way to go, but you're going to be traveling out of the country.
I'm really glad you mentioned that last point, Shari, because it may be very hard to find here are the few Medicare Advantage plans that cover travel, but that doesn't mean there aren't other options.
The G plan will cover 80% of international travel, and I think the D plan also does.
Very helpful, thank you. And someone asked, what are the penalties for changing from an Advantage plan to Part D?
There's no penalty as long as you do it during the proper enrollment periods. So you can do it now.
Great, thank you. And there were a couple questions about how Medicare interfaces with secondary payers. And specifically, there was a lot of questions about Blue Cross and Medicare, and what's covered and who pays. And I know that was a part of your presentation, Shari, but do you want to say anything more about that?
It really depends on the plan. Blue Cross has Advantage plans, they have Part D plans, and they have Medigap plans. So it depends what part you're talking about. And so it's really very specific to the plan.
I think a lot of people were mentioning that they had private insurance through Blue Cross, and how that works.
That could be their Medigap that they're talking about, because it is sold through private companies.
Okay.
Or it could be a secondary and they're working and they have a private insurance. So it really depends on the plan and the individual.
And there was a related question about how copays are determined. Can you say anything more about that? This was, I think, related to when someone has secondary coverage, but can you say more broadly about what people should expect related to copays?
Generally, copays are somewhere between $20 and $50 or 20%. And again, it depends on the plan. So there could be copays for your Part D plan. There could be copays for your Medicare Advantage plans. A lot of Advantage plans have eliminated the copays for primary care physicians and then have a $45 copay for a specialist. The plans determine those things. They clear them with the Centers for Medicare and Medicaid, and they get agreement and they put them out there. And they vary from plan to plan, which again is why it's so important to check your plan every year to make sure that not only that you're on the right plan, but you understand what you have and know what to expect.
And I might piggyback on what you're saying, Shari, to say it kind of gets into that, what's your primary and secondary insurance? I mean, with Medicare as your primary, there's a set of copays that get updated every year, but whatever your secondary is, private Medigap plan or Medicaid, they often can pick up some of that cost so that it either lowers or eliminates that copay. depending on the plan. So I completely agree with Shari, it depends on the plan, but just to say that the whole point of those secondary plans is to lower your copay so that it's affordable.
And the Medicare 2024 book, I think it's on page 60 or 76. I'm not positive, but it does show you the Medigap plans by letter and what they cover and what percent they cover. It doesn't show you a dollar amount because that's varies, but it will show you that, for example, with any of the Medigap plans, it will cover your first 3 pints of blood, for example, where Medicare doesn't cover that. So you can get a sense of what blanks will be filled in by the Medigap plan. And you can also download that book at medicare.gov.
I loved I think it may be page 76. Obviously, you've been through this backwards and forwards many times.
It's always somewhere in the mid to high 70s, and I'm just not 100% now. Although I do have the book, I can tell you if you want to go on to the next question, I can tell you.
We're very lucky to have two experts here because clearly you both know your stuff. A very general, basic question here. What is the advantage of having Medicare if I'm a healthy adult?
You're a healthy adult today. You don't know what's going to happen to you tomorrow. And it's insurance. It's just like getting automobile insurance. You don't get it when you have an accident. You have it before, so that if you have an accident, you're covered. And healthcare costs are out of control. You don't want to be hit with bills for being uninsured, and you don't want to be hit with late enrollment penalties if you end up signing up for Medicare later. So, you know, it is insurance, because you just don't know what the future is going to bring for you.
Yeah, I agree with Shari. I mean, that last point I'll just underscore, yet those late enrollment penalties can accumulate. So if you've waited years, they're trying to disincentivize that from the program. But I will say the prevention is the big thing. I talked a little bit about that. I could say a lot more, but just in essence, you want to prevent having those big health complications. And if you can do that with some initial screening tests and, maybe you need a medication, maybe you don't. Sometimes I see people who haven't seen a doctor in decades, and most of the time you're thinking, oh, they're fine if they got this far, but oftentimes we just kind of detect new things that they weren't aware of. That's just, maybe it's blood pressure that is not something you'd feel symptoms from, but that's very high and that could put you at risk for a heart attack or stroke. That's just one example, but obviously we want to prevent catastrophic things from happening too.
Absolutely.
Thank you. And someone asked, if I start taking Social Security at 67, do I pay for Medicare premiums for 2 years out of pocket, or will it be applied to future incoming Social Security benefits?
If you take Social Security at 67, but you went on Medicare at 65, is that what I'm understanding the question?
I think that's, yes.
Yeah, then you'll pay your copays out of pocket, or your premiums out of pocket until you decide to have them taken out of your Social Security. And I'll add, you don't have to have them taken out of your Social Security. You can pay them online or write a check every month. It's just a whole lot easier to have it taken out of Social Security, because then you don't risk falling off Medicare.
Thanks, that's very helpful. And we received a number of questions about from U of M employees about how U of M plan options, decisions about U of M plan options. I just was wondering if you wanted to say anything more about how people who receive benefits through U of M can navigate the options available to them.
I would say that they really need to contact their Human Resources Department for assistance on that. If they come to us with all the different plans and want to compare them with Medicare plans, we can do that, but it's much more efficient to talk with Human Resources.
Yeah, I agree. And there's we can maybe as a follow-up, there's some contact information we can provide, since there were so many questions related to UMM employees, but talking to our Human Resources Benefits Manager, they have a contact information website, because there are so many options. U of M has its own Medicare Advantage plan now. There are different options for whether you're a retiree or current employee. So there's a lot of different circumstances to go through.
And one thing to be aware of, and I'm not sure if that is true with U of M, but if you don't take your employer insurance retirement plan or you drop it, you may not be able to get it back. So it's something to ask about and be cautious about as well, because there are some employer plans that you lose it if you drop it.
And maybe kind of the opposite scenario here. We have a question about, I have Part A, but not Part B because my spouse works for a place that offers health insurance. When she retires, how long do I have to sign up for Part B before I'm penalized?
You have 8 months. And make sure you get a letter from their human resources. I can't think of the number of the form, but there's a form that your human resources should know that they have to fill out and that you have to fill out to show Social Security that you had credible coverage so you don't get hit with penalties.
That's very helpful. There were some questions about limits on a person who's receiving care in subacute rehab. Limitations on Medicare coverage for subacute rehab.
Yeah, so Medicare pays that post-acute care after a hospitalization for usually up to 21 days. And then, or fully, and then it gets to different percentages. With Shari may know off the top of her head, but I don't remember. But it ends up being a lot more expensive after that time period. Some people obviously need longer subacute rehab stays depending on their health condition. And so we often see this when discharging people from the hospital, trying to find the right spot where they can get that initial care. And if they need longer care, that there are affordable options for people.
I'm sorry, I don't know those numbers off the top of my head.
Oh, that's okay. Yeah, no, I was gonna say, I know it just goes up significantly.
Yeah, it does.
Too, but I don't remember what the percentage is. But this is probably a good time to just remind people that Medicare doesn't cover the skilled nursing facilities for long-term care, which oftentimes people think it does, but it's really specifically the benefit is for post-hospitalization rehabilitation, like this person asked.
And I wanted to, I guess, just end with one more question, I guess, and this question is specific to what Shari, your program offers, but they wanted to know whether this person wanted to know whether MAP offers general and ongoing instructions that don't depend on any specific, having a specific question, like a tutorial that people can tune into or read.
We offer Medicare 101 presentations all around our 6-county area. I'm sure that we could share something with you. You can also call us and sit with the counselor and sort of get a tutorial on your own. And I might also add that if it's something that you're really interested in, if I can just put a plug, we run primarily through volunteers that go through extensive training. And if anybody finds this really fascinating and says, hey, I'd like to become a MAP counselor, please reach out to us, leave that message, because we're always looking for new counselors who can work one-on-one with beneficiaries.
That's a great opportunity. Thank you, Shari. Well, I'm gonna, I see that it's 1:30 here, so I'm gonna wrap this up. I'm sorry that we didn't get to all of the great questions today, but I wanna thank everyone for joining us. We know this is an important and complex topic, and there are lots of decisions to be made by December 7th when open enrollment ends. But we hope that this session has helped you to learn more about your options. I wanted to reiterate, as Shari noted, that you can submit a request for an individual appointment to discuss your specific situation with a MAP counselor by calling, again, the number is 800-803-7174. And as Shari mentioned, you'll need to provide your zip code first so they can direct you to the appropriate resource in the state. And another reminder that the recording from today's session will be available in the coming days. And please feel free to review the material or share it with others who might be interested. And finally, please be on the lookout for an evaluation form, because we really appreciate your feedback regarding this session, and it helps us to prepare for future events as well. So thanks to everyone for being here today, and thank you very much to our presenters.
Thank you, everyone.